Complex topic, and I would like to engage everybody in how to manage arrhythmias in various, with the latest technologies. So we know that the cardiac rhythm or electrical rhythm of heart originates in the atria, and then it travels after stimulating the atria, it travels through the His bundle and then stimulates the ventricles. And there can be various rhythm disturbances starting from atrium. There may be sinus tachycardia, sinus re-entry, sinus arrhythmia, then various types of re-entry in the atrium, and then in the junction like AVNRT, AVRT involving accessory pathways. And in the ventricles, we can have ectopic beats, we can have non-sustained VT or ventricular fibrillation or ventricular tachycardia. So why are arrhythmias important? Now there are obviously two reasons. One is that they may cause symptoms in some patients. So some patients may be totally asymptomatic yet having a lot of PVCs or atrial fibrillation, or they may have mild, moderate or severe symptoms. And on the other side, there may be a risk of arrhythmia. So arrhythmia may be totally risk-free, like for example, atrial fibrillation or PVCs in many patients may have very little risk, but they may also cause heart failure if the arrhythmia is sustained for a long time, like atrial fibrillation with faster rate or any other ectopic atrial tachycardia. Any arrhythmia can cause heart failure if it sustains faster heart rate for long periods of time. And some arrhythmias may also be associated with the risk of sudden cardiac death, especially ventricular arrhythmias in presence of structural heart disease. When somebody has a heart disease and has reduced LV ejection fraction and there are ventricular arrhythmias, they can lead to sudden cardiac arrest and increased mortality. So as physicians, what are our options? We have options of giving drugs to the patients, antiarrhythmic drugs. At one time, very few antiarrhythmic drugs are available, but increasingly they are available in our country. We now have flecainide, propafenone, which are not available earlier. Earlier we had only amiodarone and digoxin and beta blockers. Now we also have other antiarrhythmic agents available, and increasingly more and more will come, but they have their own limitations. So we have catheter ablation, which is a curative therapy where we map the exact source of arrhythmia, the cardiac tissue that is causing arrhythmia, and we ablate that tissue. We make it electrically inactive. Thirdly, for acute arrhythmias, we have cardioversion defibrillation when we feel that the patient is unstable or may have serious problem and we want to get the patient out of arrhythmia quickly. We have to cardiovert or defibrillate. The difference being that defibrillation is done only in one arrhythmia, that is ventricular arrhythmia. Everywhere else we have to synchronize the electric shock with the QRS complex. So it's called cardioversion. And then we have various types of device therapies, whether for bradyarrhythmias we have pacemakers, for tachyarrhythmias we have implantable defibrillators which monitor the heart rhythm, and in case of emergency it can deliver a shock and therapy, other therapies, and save life of the patient. Now the problem with the drug therapy is that they are not curative, they are suppressive in nature. An example I give a patient when they say we can take drugs, I can say it's like taking crocin for malaria. You can cure it, but you don't want to take suppressive treatment. So, and they can have side effects, but they have their utility. In acute settings, when the patient is in CCU, we have to control various arrhythmias with drugs before a more definitive and long-term therapy can be given. And often, along with ablation and other therapy, they have to be used in as adjunctive therapy. So antiarrhythmic drugs are useful, there is no doubt about it, but whenever possible, we like to go for curative ablation therapy. So what has changed the management of arrhythmias in last 2-3 decades is electrophysiology study and associated with catheter ablation. So what we do here is we place several catheters inside the heart. They are all multipolar catheters. We position them in critical locations like high right atrium, His bundle location, coronary sinus and ventricle, and record electrical potentials from there. And after analyzing them, we can find out what is the exact origin and mechanism of arrhythmia and what is the prognosis of that particular arrhythmia and how it should be treated. So there are various catheters available of different shapes and sizes to position in different parts of heart, and they all have varying number of electrodes, and we record ECG from there. And this is a typical setup of EP labs, like a cath lab, actually a cath lab with some additional equipment. So we have a person helper sitting outside monitoring so this is how intracardiac ECG looks like. And increasingly, of course, we used to analyze it ourselves, but now increasingly we have machines are getting more intelligent and they can analyze it for us, and we can then get to the source of arrhythmia. The main indication for EP study would be unexplained syncope, where Holter and head-up tilt test and other tests are not, they don't solve the problem. We do EP study. For patients who have palpitations or undiagnosed arrhythmias, patients who have risks for stratification for say structural heart disease, some patients have ectopic activity and they have depressed LV function, so we must do an EP study to see if there is any inducible ventricular tachycardia. And those patients who have inducible tachycardia by giving a premature beat in the EP lab can also have any same tachycardia when they get a same time similarly timed premature beat outside. And of course for every ablation we have to do mapping, and then only we can ablate. Now, what is catheter ablation? Catheter ablation, okay, so catheter ablation is basically it's use of a electrical energy to coagulate the tissue that is responsible for arrhythmia. And here we use a special energy, it's called radio frequency energy. So which is basically a very high frequency energy. Normal AC current is 50 cycles, 60 cycles per second, and this is 5 lakh cycles, 6 lakh cycles per second. So it's not felt by the human body, and it can just cause heating of the tissue. And there are various types of catheter which are flexible. We can position them anywhere inside the heart. And they have a very technologically advanced tips which have multiple electrodes and various mechanisms to monitor the pressure and other things. So I will not go into the details of that. And recently something which is coming called pulse field ablation, where it doesn't involve heating, just cell death, apoptosis or cell death. So it is now considered to be more safe. It is yet to come in our country. It's just come in mainstream last year only. So we will soon have pulse field ablation also. But what has changed the practice of electrophysiology is this 3D mapping. I was saying that machines are getting more and more smart, and they can, just as we have color Doppler, we have different velocities are coded, color coded, and we can see the mitral regurgitation and other things. Similarly here we can see the activation of heart by different color codes. So different time, when the impulse travels through the heart, every isochrone is given a different color, and we can see from where the arrhythmia is originating. Now this is a right atrium and left atrium map, and this is ectopic atrial tachycardia. And we can, the same map, we can also see the propagation as to how the impulse is spreading through the heart. So I will not go into the details, but the major indications of catheter ablation are supraventricular arrhythmias like AVNRT, AVRT, WPW syndrome, atrial flutter, focal atrial tachycardia, all kind of supraventricular tachycardias. Atrial fibrillation is also ablatable, but the success rate is less, about 70%. Ventricular tachycardias, again, idiopathic or scar-related tachycardias can be ablated, and in many cases, the PVCs, ectopic beats, are also to be ablated, especially if they are causing LV dysfunction. Now, some specific arrhythmias, like for example, PSVT, we sometimes encounter these patients who present to us with palpitations and narrow complex tachycardia, and they may have two physiopathologies generally, either AV node re-entry, where there are two pathways within the AV node, or there may be a accessory pathway, which is like sometimes manifests as WPW, sometimes it doesn't cause pre-excitation on the ECG. But we can, when they present with PSVT, we have to break the tachycardia with the help of adenosine or injection Delzem or verapamil, or sometimes rarely DC shock. But for prevention of recurrence, catheter ablation is now the treatment of choice, because it is curative, it's safe, and it gives complete cure without any long-term, lifelong drug therapy. So it has now been recommended as a class 1 therapy for PSVT patients because of its curative nature and the freedom from side effects and long-term use of drugs. Similarly, atrial flutter is again not a very uncommon arrhythmia. We often encounter patients. This patient has been given drugs, so the rate is less, but sometimes they present with very fast rates, 150, 160. And it can cause palpitations, or it can aggravate heart failure, or it can sometimes even induce heart failure if it's sustained for a long time. And again, after acute conversion of atrial flutter with drugs or shock, we go for catheter ablation. Long-term catheter ablation can give long-term success. So again, we can do 3D mapping to define the circuit of atrial flutter, which is a large reentrant circuit in the atrium. And generally it passes through this, we do ablation in this region, cavo-tricuspid region, between the tricuspid valve and the inferior vena cava. And again, it's a class 1 indication for ablation of atrial flutter. Atrial fibrillation, we all know that previously we used to believe that it occurs because of multiple wavelets of re-entry, which is still the case for many patients. But increasingly we have understood the role of pulmonary vein ectopic activity. And now pulmonary vein isolation has become a standard treatment for treatment of catheter for atrial fibrillation. And especially patients who are younger, who are very symptomatic, there we recommend the use of electrophysiology and catheter ablation. And what we do here is the most common procedure is pulmonary vein isolation, where we create conduction line blocks along the periphery of the pulmonary veins. So that's how it is done. These are the areas which are responsible for initiation and sustenance of atrial fibrillation, ectopic activity in the pulmonary veins. And we either create, through the RF catheter, we create lines of conduction block around the pulmonary veins, or we can also use cryo balloon, which has similar efficacy to catheter ablation, a bit more expensive but similar efficacy, but simpler for the doctors to perform. And after ablation, we can see that they are electrically isolated, the pulmonary veins are electrically isolated. So pulmonary vein isolation has become cornerstone of AF ablation. It improves symptoms and quality of life. The success rate is still less, around 70% in general. Some patients may have 80% chances, some may have 40-50%, especially those who have significant hypertrophy or heart failure or dilated left atrium or right atrium. There the chances of success are even lower, 40-50% maybe, or maybe even less. So we look at all these factors before we subject the patient to catheter ablation. Ectopic atrial tachycardia, another not very rare tachycardia where there may be ectopic focus within the atrium, and there are various locations which are commonly commonly see, cresta around the pulmonary veins, around CS, os. And again, we can perform EP study and we can locate the source of this ectopic activity, the location of focus of the ectopic tachycardia, and we can ablate it. So that's very effective. Coming lastly to ventricular arrhythmias. Now this slide encapsulates everything about ventricular arrhythmias. At the center what we have is a substrate which is causing the ventricular arrhythmias, which could be either a post-MI scar from where the VT or ectopic activity originates, or it may be a scar in cardiomyopathy patients or channelopathies like Brugada and other channelopathies, and they may cause either triggering arrhythmias which are not harmful. PVCs and couplets and non-sustained VT, they are not harmful, they are only called triggering arrhythmias. But in presence of substrate, they may cause potentially lethal arrhythmias like ventricular tachycardia and fibrillation. And there can be various modifiers, so which may convert a stable substrate into unstable substrate, which could be somebody having ischemia, somebody having hypoxemia or electrolyte imbalance, and changes in the autonomic nervous system. They can all trigger an episode of VT in a given patient. So somebody very happy suddenly goes into ventricular tachycardia, fibrillate. Somebody gets a shock, or somebody does intense exercise, or has some diarrhea with hypokalemia, goes into VT, and so all these modifiers can acutely precipitate ventricular arrhythmias. So when we look at these ECGs routinely in our OPD, we don't need to worry, but we must rule out structural heart disease. At one time it was only TMT and echo that were necessary to rule out structural heart disease, but nowadays we also look at cardiac MRI before we say that the heart is structurally normal. So if the heart is normal, then we don't need to worry about ectopic activity. We can just give beta blockers for symptom control. But if the patient has structural heart disease, then we should perform EP study to define further risk and arrhythmias, and that is the guideline also. As far as sustained arrhythmia VT is concerned, there are two arrhythmias which are very easily ablatable. One is called idiopathic RVOT VT, which has LBBB type morphology, and here the ablation is class 1 treatment. And the other, as we commonly know, is idiopathic fascicular VT, which has a RBBB morphology and superior axis, so 2-3 AVF will be negative and V1 will be positive. This arrhythmia presents like PSVT and is managed like PSVT. ICD is never recommended for this, and catheter ablation is the treatment, and offer response to verapamil also, just like PSVT. So PSVT can be used for prevention of episodes also in this arrhythmia. Here again the treatment is catheter ablation. Now lastly is SCAR VT. SCAR VT is like patients who have had myocardial infarction and are getting repeated VT, often syncopal VT. And this is how it looks like, very dangerous kind of VT. And what happens is that when somebody has a myocardial infarction, and if it's a dense infarct, very big dense infarct, it doesn't have too many circuits. But when the infarction is patchy and there are strands of viable muscle between the scar tissue, that is where the VT circuits live, and that is where the VT originates, and it can sustain itself. So, and these are the patients where again we can map this scar, we can map the circuits, and we can perform catheter ablation today very effectively. So we can either go to the periphery of the scar, that's where the circuits are found, and there are some central channels. So that is where the VT circuit exists, and we can map and ablate, and also modify the scar sufficiently so that future arrhythmias don't occur, and we keep checking the inducibility in the EP lab. So here again, it has become a class 1 indication now to perform. So I think I am very much in time. So the key messages are that we must categorize the arrhythmia according to the risk as well as symptoms. Both are important. Some patients may be totally asymptomatic but may carry tremendous risk. Others may be very symptomatic, but we say don't worry, you don't have risk, so only we have to control the symptoms only. So that's very important. EP study can be done if diagnosis is not clear, and also to assess prognosis. Drug therapy reduces frequency of arrhythmia, but it's not curative in most cases, so it can be used either as a transient till the patient gets ablation, or as an adjunct if the ablation is not fully effective. But the curative ablation of arrhythmia should be preferable whenever possible. And implantable defibrillator is for those patients where the risk of sudden cardiac arrest is very high. So we can implant the ICD in those patients. I'll be very happy to answer. Thank you for listening. If there is any question, I'll be happy to take it. Thank you.
Thank you, Dr. Saxena. Such a nice presentation given by you. Now the session is open for any questions from any audience.
No, around 95%. And flatter. Fibrillation, yeah, 70% chance of success. But others where the ventricle is hypertrophied or atria are dilated, it may be lower also. Especially like hypertrophic cardiomyopathy patient, they don't respond very well to ablation because the muscle is very thick and hypertrophy non-compliant, and they have very, recurrence rate is very high.
In generalopathy, is it preventive sudden cardiac death by doing this study and
in generalopathies, generally generalopathy lead to ventricular arrhythmias, and ablation is not very effective. But if the patient is having very frequent arrhythmias, and despite ICD, if the patient is getting very frequent ICD shocks, then nowadays there are case reports in some series where in Rugada also they have done ablation and it has been found effective. But that is not a primary treatment for generalopathies.
Sir, here I am.
Yeah,
I am Dr. Sajid from Lucknow, sir. So many times we hear our lecture, sir. My two questions. While having patient of AV and RT, in your algorithm you mentioned IV dilzam and adenosine. But is it true that while giving recurrent, there is patient is coming? So what is the time of transition when you are choosing, no, now we need to RFA for this patient? So recurrent, how?
So my approach is that if somebody has first episode at say 40 or 50 years, we don't know when the second episode will happen or will happen at all or not. So we can ask the patient to, if they don't want ablation, we don't press. We say, okay, you can just follow without any treatment because first episode has happened so late in life. But provided the episode was well tolerated. Some patients have very high rate during PSVT, 250 or so, they have hypotension. We have seen cases presenting with syncope and they were found to be in PSVT. So if it is well tolerated and mild symptoms, they can follow without any treatment. If the patient has frequent episodes or very symptomatic episode or hemodynamically impactful episode, then certainly ablation is the right treatment.
Okay, sir. Thank you.
But whenever we have to give treatment, then ablation is the treatment. Drug therapy is not a choice.
You mentioned just now morphology of LA. while responding on question, where are you putting morphology of LA and LA strain while deciding this patient need to go for ablation or not?
Yes,
I am taking some other way. LA strain is, especially reservoir strain, is very important for this.
Very important and recently recognized, and till now it never used to be part of routine echo studies. And even now we have to specially request.
I am doing some routine.
Now we have to especially request that please look at LA function and look at LA size more carefully, because we have to take a decision about ablation based on that. So if the LA size is more than 5, then chance of success are less, and beyond 6 we don't recommend catheter ablation. So
Thank you, sir. And one more question. You mentioned in your presentation, CMR is now a routine while looking for this LV and structurally hurt. And this is a very burning reporting of CMR is what we are doing in our practice. Patient of PF and subhypertrophic cardio, okay, send for CMR. But it was a blanket statement by your slide. So when you are putting for a CMR, HFrEF, what we can get from the HFrEF?
So what happens is that,
so what you are doing,
yeah,
sir?
so in the patient presence, especially with ventricular arrhythmias, to assess the prognosis of ventricular arrhythmia like PVC, etc. Somebody comes with 5,000 PVCs on Holter, 10,000 PVCs on Holter, and no symptoms. So we say, okay, we must assess whether your heart is normal or abnormal. If it is normal, nothing to worry. PVCs are not harmless. But to declare that the heart is structurally normal, previously echo and TMT were considered sufficient. But nowadays, because there are so many myocarditis which we are increasingly recognizing, sarcoidosis, even tuberculosis, amyloidosis, so many myocarditis and structural heart disease, types of myocardial diseases, that MRI has become essential. But your point is very valid that reporting of MRI, even in NCR, we find it very difficult. Very few experts can because the knowledge base doesn't exist much, and the basically expertise is also evolving as people are recognizing patterns, associating with them with certain clinical outcomes. So globally also, cardiac MRI is a relatively new field, and there are very few real experts. So that problem exists. I completely agree with you.
Reporting of CMR, is it a problem, or can we take help of AI in this?
AI will be revolutionary for cardiac MR, definitely, for imaging especially, because it can identify pattern when you feed millions of patients' data along with their clinical outcomes. AI, even on routine ECG now, AI can pick up in sinus rhythm. It can pick up which patients are having episodes of atrial fibrillation or who have LV dysfunction, cardiomyopathy. So AI is very, very powerful, and is going to get more powerful.
Share my experience. Dr. Sanger and my all colleagues were working. We were doing some work on hair-dye poisoning. Hair-dye poisoning, and the patients were having. We used to see the patient was okay in the evening time. When we went to the next day for round, patient is no more. And it happened 3-4 times. It was really worrying why it is happening. Ultimately, we found those patients were having myocarditis with ventricular fibrillation, and that was causing the problem. And that was only told to us with the help of MRI during that time. I'm talking about 10 years, 12, 13 years back. And we wrote a paper on that.
Yes,
we had 1,500 patients series on that, and we showed that MRI is definitely having. Echo was not helping us. They were not telling us even pericarditis we were missing, even myocarditis we were missing. But MRI helped in those patients, which was very essential to save our lives. Then we changed our pattern to treat those patients of hair dye with myocarditis.
Sir, one more query is about echo is of course very helpful, but MRI can more accurately define the anatomy of this thing and the measurements and all that. And again, there are multiple probable or possible or definite. So guidelines are very detailed, and we cannot go through them now. But whenever we suspect ARVC, we have to largely follow these patients. If they don't have arrhythmia, we generally don't implant ICD, etc. But when they have clinical arrhythmias or history of syncope or family history of sudden death and all, then we like to implant ICD in those patients.
I've been told that we still have 5 minutes by the clock for lunch. So this is going to be the last pre-lunch session, and as per Dr. Jain, yeah, so we are shifting. We'll be breaking for lunch at 1:30.
Dr. Akhil is not coming. So we will keep the same sessions.
So
Beta blocker are less effective. AV node blocking agent has to be given, and verapamil is very effective, but it should be given only if the patient does not have a pre-excitation on ECG. Because patients who have WPW syndrome, they can have serious problems with verapamil, because by blocking the AV node, it may promote conduction through the accessory pathway, and patient can have ventricular fibrillation and sudden death in case they get atrial fibrillation episode. So during AF episode, it can increase the rate paradoxically. That's why we don't like to use verapamil in patients who have pre-excitation on ECG.
I wanted to ask one question. Post-COVID, we've been using digital BP instrument devices, and we've been seeing a lot of patients who come with asymptomatic sinus tachycardia. Like when you record their BP and heart rate is in the tune of 130, 135 and all. Otherwise, they are pretty comfortable. They have no complaints. So normally we add ivabradine, and after getting Ecodant, what do you recommend? Are we missing out on anything or anything else that needs to be done in such patients?
Yes, I think very good question, because sinus tachycardia as such, first of all, it correlates with adverse prognosis. Heart rate ideally should be, resting heart rate should be between 60 and 70. As the heart rate increases, in general population, the prognosis of the chance of cardiovascular disease and early death increase. So it is good to have lower heart rates, and we are increasingly recognizing an entity called idiopathic or inappropriate sinus tachycardia. And post-COVID, also maybe the frequency has also increased, but the recognition has definitely increased, because many people are having these consumer-facing devices, whether they're BP instruments or oximeters or watches or all these consumer-facing devices. They have increased awareness of patients about their heart rate, about the abnormalities of heart rate, and in many cases it's causing undue anxiety, unnecessary anxiety also. But many cases are being picked up also. So as you rightly pointed out, first of all, we should look at if there are any lifestyle factors which are causing tachycardia, including too much of caffeine intake, no exercise, obesity and all that. So we first focus on lifestyle modification, and if that doesn't work, then ivabradine is a very good choice. Even low dose beta blockers are quite safe and they can be used, sometimes alone or in combination with ivabradine.
Sleeping heart rate has to be examined first.
Yeah.
If sleeping heart rate is normal, then this is not related to any drug.
If they to rule out anemia, right?
Thyrotoxicose, all
High
these things should be
cardiac
ruled
output
out.
states, yeah,
Should be ruled
right.
out.
Sir, one small question. Sir, patient on amidone for VTR VM. So I have any side effect with amidone?
And it is a very toxic drug, so we don't like to use it.
Okay, thank you.
डॉक्टर रानी कपूर सर, हमारे झांसी की शाद. Give a big round of applause to our honorable speaker for this wonderful session.
Yes, sir, देखिए.
A wonderful lecture today.
सर आप भी थोड़ा सा आगे आ जाइए. हाँ बस अब ठीक है.
Now I request our honorable speaker to kindly felicitate our chairperson.
सर आप भी आ जाइए.
Thank you. Thank
Yes,
you.
yeah, देखिए.
So we have an important announcement.
ठीक,
We
sir.
now break for lunch. We have a lunch break for half an hour. And post lunch, we
Sir, yeah,
resume
देखिए.
sessions in the same order. Like we would be beginning with the lecture of Dr. Sanjeev Gulati on CKD
Yes.
post lunch.
ठीक सर.
And time is
Yeah. So we come back. We are assembling at 2 o'clock sharp.
यस यहाँ देखिए सर. ठीक सर, थैंक यू.
Chaliए सर.